Happy Friday, everybody. We got 3 cases today. It's a gorgeous morning here, Gilbert, Arizona. So 3 cases today. Our first case is a PRP procedure for some shoulder instability. So we got some glenohumeral instability along with some wrist pain. Patient had an injury to the inside of the wrist joint, took a fastball to it. And so he had some ligamentous damage, a little bit of bone bruising. And so we're gonna treat that with some PRP. And he also appears to have a lumbar plexus entrapment that is causing some hip pain, some hip weakness that doesn't actually seem to be coming from the joint. So that's first case. Second case is a stellate ganglion and cervical sympathetic chain block. So we're gonna do that for a patient who's been having some pretty severe anxiety and some intermixed with some PTSD. And then our last case is a little bit more of a complicated case, but a patient who is having some significant pain after a total hip replacement, which was followed by a revision. And he currently has a lateral femoral cutaneous nerve entrapment that is causing him some significant pain, some neuralgia, paresthetica, along with pain with that. And so we are going to get that treated up today. Sorry it's loud here. We are gonna get going, let's do it. All right, everybody, another episode of Fridays at RP. So we are gonna cover 2 procedures that we did today. Now, our first procedure is a little bit more of an involved procedure. So we had a patient who was having some anterior hip pain that was also a little bit into the abdomen and a little bit kind of down the anterior aspect of the leg. And he had had prior regenerative injection treatments before into the glute med enthesis, into the hip joint, and into a few different structures, but didn't really have a positive response. Now, our physical exam demonstrated that there might be a lumbar plexus entrapment neuropathy, which was resulting in some pain over the nerves that pass through the lumbar plexus. So it's gonna be nerves like our anterior femoral cutaneous nerve, our iliohypogastric, ilioinguinal, and all of those kind of provide innervation over that lower abdomen, and then also into the anterior aspect of the hip and then the thigh. And so we performed a lumbar plexus hydrodissection for that. That was always a fun procedure to do. In conjunction with this, he also has some shoulder instability, mainly in the overhead position. Now again, when he had regenerative injection treatments for the hip, he also had that shoulder treated, but didn't really see a positive response from that. And so our approach, while he did have some of the glenohumeral ligaments treated at that time, unfortunately the notes from that provider were not sufficient for me to know actually how much of that entire rim of the anterior and the posterior glenohumeral ligaments were treated. And so we decided to take a really comprehensive approach in that. And what was interesting during our injections is that on the posterior aspect, when we were injecting at the most posterior and inferior aspect of those ligaments from the glenoid onto the actual humerus, and we were at this point injecting onto the glenoid, is that we recreated some of those sensations of instability he was having in that overhead position. And so we haven't really seen that a whole lot, to be honest, where we recreate a sensation of instability, but it was familiar enough to him that it sounded like we were in the right area for that. Now, one of the other interesting things we did with that case is that we hydrodissected 2 different nerves. We hydrodissected the suprascapular nerve at the suprascapular notch, and then also at the spinal glenoid notch, 2 places where we can see entrapment neuropathies. And then we also hydrodissected the axillary nerve, and specifically the superior lateral brachial cutaneous nerve, as it is passing through the quadrangular space. And so our reason for that was that when we have these sensations of instability, that can sometimes be a result of poor motor control, which is obviously a connection from the brain down to the muscle and involves nerves. Well, a lot of the times it's more of a central proprioceptive issue, but sometimes we can see alterations in the motor function from different nerves if they've been injured in the past. And so our physical exam suggests that, hey, maybe these nerves are involved in his perception of instability because they are not functioning the way that they should. And so we hydrodissected those nerves in those 3 locations. And then lastly for him, he was having some right-sided wrist pain that actually, it was more of a traumatic injury. It's not more of a chronic degenerative thing, but he basically took a fastball and took it right to the inside of the wrist. And so from that, we suspect that he had a little bit of ligamentous damage in that interosseous ligament, that membrane between the radius and the ulna, along with some of the ligaments on the medial aspect of the wrist. And so under ultrasound guidance, we hydrodissected some of the nerves in the area that could have been contributing to some of his pain. And we injected along the ulna, along with the ligaments for the medial aspect of the wrist. Again, recreated a lot of this patient's pain, so we're really, really excited for that. So our last case of the day was a really, really interesting and unfortunate case. So this patient is 15 months post total hip arthroplasty. So that's a total hip replacement. He then had a revision 3 months ago. So at the 1-year mark, he ended up having a revision for a suspected loose stem, along with some other complications. At one point, he had a hematoma develop. He also might have had a septic joint and things like that. And so he's been in a lot of pain for quite some time. Our physical exam with him was obviously really difficult to do because he's in such intense pain, 1, from the recent surgery, but 2, just everything that's been going on. And so our approach with him was to start really superficial and work inwards in our approach such that we could start to peel away the layers of pain and work from the outside in. So basically, instead of going in and treating some of the things that I thought needed to be treated, such as the glute med and glute min enthesis on the actual greater trochanter, because those were extremely tender to palpation and had never been addressed in the past before, was addressing the lateral femoral cutaneous nerve. This nerve, this patient had severe allodynia over top of that nerve. So basically with very light pressure over top of the distribution of the lateral femoral cutaneous nerve, extreme pain. Now with that, we obviously want to calm down the nerve. And so we decided to do a nerve hydrodissection for the lateral femoral cutaneous nerve. So under ultrasound guidance, we found the anterior and the posterior branch of the lateral femoral cutaneous nerve and performed nerve hydrodissection around that with local anesthetic, but also with some 5% dextrose to try and see if we could calm down some of that nerve inflammation. Really excited to see how this case develops for him, and hopefully we can help him improve his hip pain. Now, he also had some mild cervical facet syndrome, so pain coming from the cervical facet. And so while we were doing this procedure, he had also decided to have those treated. And so we used Dextrose Prolotherapy, so a 25% solution, and we injected into the facet joint and into the facet joint capsules in order to help with the pain coming from his facet joint. So again, super excited for this case, and that is all we got for this week's episode of Fridays at RP. Thank you so much for watching. If you made it all the way to the end, please say hi in the comments. Would love to chat. See you later.